This is the case of a 70-year-old gentleman with a prior history of herpetic keratitis, where we deemed the endothelium to be healthy enough to perform a DALK surgery instead of a PK. After trephination to maximum depth, we attempt a big bubble technique, although we're quite certain that the big bubble will not form because of the deeper scarring. And you can also appreciate that on air inflation, a part of the air escapes through the scarred epithelium. So after the debulking of the cornea, we perform the usual deepening of the trephination groove, but unsuccessfully we create a microperforation. So we change the site guided by intraop OCT, which is not shown in the video, and after satisfactory depth is reached, we use the Sinskey hook to grab and tug at the deep stromal fibers to create a dissection plane. After that, we decompress the AC to allow the posterior corneal layers to fall back and to not prolapse outwards towards our instruments and to inadvertently create macro or even micro perforation when doing the manual dissection of the posterior layers. So using Vanna scissors, we dissect bluntly and we progress and cut circumferentially for 360 degrees. Upon reaching the microperforation that we had previously created, we inject air into the AC to allow for a better visualization, because aqueous keeps flowing out through the microperforation and hinders the view quite significantly. So air is used to improve visualization in this case by preventing aqueous outflow. After the 360 dissection is completed, we use our classical pulling technique described by Malbrun in his paper from the 70s. Because of the microperforation, we do lose part of the air, so for the last remainder of the cornea, we resort to bluntly and gently dissecting rather than pulling. So after we're done with the dissection, we suture the 8.5 graft on top of the cornea with 4 interrupted nylon stitches, and then do a running stitch, and that's the case. Thank you for watching.